me in Terson syndrome in a tertiary care center in South India. I have no financial interest. Terson syndrome is defined as intraocular hemorrhage in the setting of acute intracranial bleed, resulting in an acute elevated intracranial pressure. So, treatment options include observation in mild cases, which can result in spontaneous resolution, and vitrectomy in cases which cause significant visual loss. So, due to associated systemic morbidity, there can be a delay in the diagnosis of the ocular hemorrhage and also a delay in the surgical intervention in the setting of a non-resolving vitreous hemorrhage. The aim of our study was to analyze the outcomes of vitrectomy in non-clearing vitreous hemorrhage in Terson syndrome, also analyzes the association between baseline visual acuity, etiology, age, and timing of surgery to the final visual outcome. This was a retrospective chart review of the EMR cases of consecutive patients diagnosed with Terson syndrome from January 2014 to January 2022 at Giridhara Institute, Cochin. All patients with non-resolving vitreous hemorrhage associated with Terson syndrome who underwent pars plana vitrectomy during the same period by 5 different surgeons were included in the study. The patients with other potential causes of ocular hemorrhage, including ocular trauma, orbital fractures, diabetic retinopathy, or any proliferative retinopathy predisposing to ocular hemorrhage, were excluded. So the patients were examined at 3 different time points: at the time of diagnosis, 1 month post vitrectomy, and 3 months at 3 months follow-up post vitrectomy, or the last follow-up, whichever is later. So the examination included best corrected visual acuity in Snellen's converted to logMAR, intraocular pressure, fundus examination, and in patients with no fundus view, B-scan ultrasonography. Other parameters analyzed include age, sex, etiology of intracranial bleed, timing between intracranial bleed and vitrectomy, and any surgical complications. So the outcomes measured include the change in baseline visual acuity, visual acuity from baseline to last follow-up, and also the association of final visual acuity to the timing of surgery, age, and etiology of intracranial bleed. So after a well-written informed consent, the patients who underwent 23 gauge or 25 gauge pars plana vitrectomy were included, and additional procedures like endolasers were performed as per indication in the surgical table. So then the patients were followed up 1 month and 3 months. The results: 33 eyes of 31 patients in the age group of 22 to 73 years were analyzed, out of which 12 eyes of 10 patients underwent conservative management, 3 eyes of 3 patients were advised surgery, which was not performed, and 18 eyes of 18 patients underwent pars plana vitrectomy. So these are the baseline characteristics of patients who underwent pars plana vitrectomy. It included 18 eyes of 18 patients, of which 14 were male, 4 were female. And the mean age was 46 plus minus 13, with the age range of 24 to 73. Baseline visual acuity was 1.89 plus minus 0.5. And mean time of surgery after intracranial bleed was 108 days plus minus 65, with a range of 24 to 273. And the mean follow-up period was 5.8 to plus minus 1.2 months. So coming to the improvement, change of best corrected visual acuity, the baseline visual acuity had significantly improved with a p-value of 0.001 during 1 month follow-up post vitrectomy, and it was maintained up until the last follow-up. So coming to the etiology and visual outcome, most patients, the 10 patients with the intraocular hemorrhage with traumatic etiology and 8 patients had aneurysmal bleeds, out of which 4 patients had anterior communicating artery aneurysms, 2 patients MCA aneurysm, 1 patient internal carotid artery aneurysm, and 1 patient vertebral artery dissection. Both the groups showed statistically significant improvement in visual acuity post vitrectomy, but the difference between both the groups were non-significant. The timing of surgery: 7 patients underwent vitrectomy less than 90 days and 11 patients more than 90 days. Both groups showed significant improvement post vitrectomy, but the difference between both the groups were not significant. The age group: 10 patients were less than 50 years of age and 8 patients were more than 50 years of age. Though the less than 50-year-old group slightly performed better than the more than 50-year age group, there was no difference between both the groups. So this was a summary of all the 18 eyes of 18 patients who underwent vitrectomy and the procedures. Most patients had undergone ILM peeling also because of a sub-ILM bleed or an elevated ILM seen, and 1 patient, labeled 13, case 13, had a epiretinal membrane seen, but this patient underwent vitrectomy after 273 days post the intracranial bleed. However, the final visual acuity was 0.2, which was a significantly good visual acuity compared to the baseline acuity. To conclude, there was significant and dramatic improvement in visual acuity 1 month post-vitrectomy, and the presenting visual acuity may not be a useful prognostic indicator to assess the final visual potential. And according to Garweg et al., which was an old study, the visual outcomes were superior if the vitrectomy was performed less than 90 days from presentation. And in our study and several other studies, similar visual outcomes were seen in both the groups. The etiology and age did not seem to be associated with the baseline or the final visual outcome. Though vitrectomy could improve the quality of life of patients, it is fairly safe for the surgeon to wait for the systemic status to, if the systemic status is unstable, for surgical intervention. So this Terson syndrome, being a rare syndrome, is limited by the sample size of our study. And surgeries were performed by 5 different surgeons, so that limits the procedural standardization. And due to neurological comorbidities, many patients were lost to follow beyond the 6-month period, and this limits the long-term analysis of these patients. Thank you.